Good morning, doctor.
Oh, good morning. Okay, so it gave you an option of coming in or not, right?
Doctor?
You had an option, tú has tenido una opción para entrar o no entrar.
No, I entered. Yes, it's good.
Okay,
Dr. Francisco will came to the meeting to be the host. He will take care of this session.
okay. ¿Quién?
Francisco, Paco.
Oh, okay.
Okay.
Yeah, bien. Okay, por favor, ayuda a la gente que quiere entrar, okay? For real?
Okay.
Okay, porque yo voy a promover.
Okay. Doctor, you didn't give me the host or co-host.
Oh, sorry. Sorry.
Doctor, so sorry. I still don't have the co-host. Doctor, are you there?
Yeah,
Dr. Francisco is here. Can you make please?
Okay. oh, you can let him in. Aren't you a host? Let me. Well, you're not a
Yep.
host yet? Okay,
No, I'm not a host.
okay, let me change that. There you go.
Okay, thank you.
Yeah. Okay, now let Francisco.
Yes, please give co-host to Francisco too.
Hello, doctor. Hello, everyone.
Hi, good morning, Francisco.
Good morning, doctor.
Yeah,
Now, what is the name of the talker today? Because I have not watched the schedule, horario.
okay, it's in English. ¿Tú quieres que yo introduce,
No,
la grabadora, la presentador?
the name of the talker is
No, Francisco, solamente dice que es in English, it's a webinar from La Paz. And give the title, you know the title, right?
Okay.
Give the title of the
Thank you.
conference and the first speaker I wrote down in the timeline.
It's okay.
Here, let me get it. Do you have the first speaker?
I found the schedule, so I'm going to say the name.
Yeah, I'm going to put it in your chat. Yeah. You know, I was just given that change. I don't even know who she is. Just Clara Martin, abordajes peritoneal and mini-peritoneal. Okay? You got that title?
Okay, doctor.
You got that title? Yeah.
Thank you, doctor.
Yeah, okay. Yeah, come to the lounge because I think we're going to have a few doctors there. We had 3 yesterday and just me and a student from Hungary that was muted. But the doctors, like I said, they're real. The doctors got to see it, and they'll understand what it is. You know what I mean, Francisco?
Yes, doctor. So I'll be there in the lounge after the session.
Yeah, after. Yeah, I'll put the link in at the end of the presentation and tell everybody. I've been kind of pushy. I barge in and say, hey, the lounge is open, but hey, that's the best way to do it. Yeah, I gotta do some promoting. Hold on. Yeah, Federico he's coming in. He's one of the neurosurgeons that was in the lounge yesterday. Federico Gallardo.
Great. Great, doctor.
Hola, Federico. Tal vez no. Buenos días, Federico.
Hola, buenos días, perdón. Había dejado la computadora.
Sí, bienvenido.
Gracias.
Hello, Dr. Margarita.
Hello, doctor.
Francisco.
Doctor, ¿empieza usted la reunión?
Margarita está allá.
Sí, está ok. No, sí, doctor González Llanos is going to introduce the first speaker.
Oh, okay. Otro cambio.
Clara Martín se llama.
Está bien, esta tecnología puede hacer bien. Puede cambiar rápido.
Yeah. Where is Pablo?
Pablo, no sé.
No, Pablo Rubino is not connected. He's here with us.
Okay, he's not here yet.
Primero. ¿Quién está primero? Carita. Sí, Carita. Clara Martín.
Okay,
The first speaker. The first speaker, we've been talking about the pterional and minipterional approach, especially the minipterional approach during all this course.
okay.
Besides
Why don't we introduce you and why don't we introduce you and you can tell the program, okay?
Okay.
Yeah, that's the best thing. Okay, Francisco?
Okay.
Okay, ready to start, Francisco?
I'm going to introduce the speaker, right?
Yeah, you introduce Dr. Llanos. Llanos
Margarita
Gonzalez. Yeah, Dr. Llanos Gonzalez, the organizer of this course.
It's okay. Dr. Margarita Llanos, right?
In English.
It's okay.
Okay, you ready, Dr. Llanos?
Yeah.
Okay, Francisco, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Hello, everyone. I am Francisco Garcia. I am part of the student team of Neurosurgery, and I'm very excited to present the speaker today. He is Dr. González Llanos, and talking about abordajes pterionales y minipterionales. Doctor, the screen and the voice is yours. Please go ahead.
Thank you. Hello. Now our first talk will be about minipterional approach, pterional and minipterional approach, and will be. I'm not going to be the lecturer. The lecturer will be Doctora Clara Martín from Cruces Hospital. You should leave her to share her screen. Clara Martín, Doctora Clara Martín. Minipterional approaches are very important because now we can handle, I would say, more than 90% of anterior circulation aneurysms through this approach. In the last years, following Dr. Mura, who was the first, the great introducer, especially in Spanish-speaking countries, this approach. In Argentina, they've been working. Here in Spain too, we've been working in with this approach, and they have worked hard in the lab to make presentations about the step-by-step dissection of this approach. And in the end, they've used this approach in many cases, many real cases. And so Dr. Clara Martín is going to show us their experience in the Cruces Hospital in Buenos Aires. So go ahead with Clara.
Okay, good afternoon. Thank you very much. Thank you very much, Dr. González Llanos, for the invitation. And of course to Dr. Rubino, who is my mentor and is constantly teaching me and giving me these amazing opportunities. So we're here to talk about the minipterional approach, and we wanted to compare the clinical and anatomical results of this approach with the pterional one. I'm sorry, are you seeing my screen?
Yes.
Yes.
Okay, great. So to start with, we know the pterional approach is a very popular one in neurosurgery because it allows us to treat many lesions due to its versatility, and it was popularized by Dr. Yazarhill. Nevertheless, we know it is not free of complications, mainly the temporalis muscles atrophy, which gives the patient some pain in mastication and some bad outcome aesthetic results. That's why there's been different modifications done to this approach until in 2007, Figueiredo popularizes the Minipterional approach. So we decided to describe the stepwise technique of this approach in cadaveric dissections and also in patients, and later to compare it with the Pterional approach in its results and complications. Therefore, we did some comparative cadaveric dissections of both approaches, and later we did a retrospective study with the patients in our institution, Hospital El Cruce, and in a 1-year period, we included those patients who were microsurgically treated for incidental aneurysms and also low-grade subarachnoid hemorrhage aneurysms, excluding those patients who had brain swelling or hematomas. So we will begin with the description of this approach. The positioning of the head is the same as in the Pterional approach. So first there's elevation of the head in order to improve the venous drainage. There's deflection of the head so that the frontal lobe goes down with gravity, and also a slight rotation, contralateral rotation of 15 or 20 degrees in order that the sylvian fissure is in a parallel view for the surgeon. And the incision, we can see it starts 1 centimeter above the superior edge of the zygomatic arch and just below the hair implantation, goes in an arciform way until the ipsilateral mid-pupillary line. We have this picture of the cadaveric dissection in the left and of a patient in the right. We continue later on with the interfacial dissection in order to protect the frontal branch of the facial nerve. So the key point in this approach, in the Minipterional approach, is that the craniotomy is totally performed below the superior temporal line. That means that in the reconstruction phase of the approach, it will be covered completely by the temporalis muscle. Therefore, we can see how later it will prevent a hollow in the craniotomy, which is sometimes the main complaint in the Pterional approach. Then we continue with the sphenoidal wing drilling, as in the Pterional one, until the meningoorbital band, who we know it marks us the limit of the superior orbital fissure. The dura is opened in an arciform way with an anterior base. So we can see how the approach exposes the inferior frontal gyrus, the sylvian fissure, and the superior temporal gyrus. We won't get into detail of the Pterional approach, who is widely known by everyone, but we can see the main differences. The incision in the Pterional approach starts in the superior end of the zygomatic arch and goes until midline. We remember the Minipterional approach was 1 centimeter above, a little bit more anterior, and until the mid-pupillary line of the same side. We continue with interfacial dissection, and we know that the craniotomy in the Pterional approach goes a little bit more to the frontal bone. So in a 1-year period in our institution, remember the inclusion criteria of our study were the incidental aneurysms or low-grade subarachnoid hemorrhage, ruptured aneurysms. We have 63 patients who were treated by microsurgical clipping. 38 of them were with a pterional approach and 25 with a minipterional. In both groups, we had in minipterional more incidental cases compared to the pterional, who had more subarachnoid hemorrhage. And the mean aneurysm size was very similar, 6 millimeters to the minipterional, 8 millimeters with the pterional approach. Here's the first significant difference that we had, which was the surgical duration, which was 90 minutes more for the pterional approach. And this gave us, was significantly different. And the hospital stay, which we only compare it with the incidental aneurysms of both groups, because we know there's a difference in the hospital stay when there's a subarachnoid hemorrhage. And we had another statistical difference where we had a less stay in the minipterional group. Regarding statistics results, we asked the patients, each of them, to grade their satisfaction of the statistics results in a scale from 0 to 10, being 0, very unsatisfied, and 10, very satisfied. As well, we had a significant difference in this thing. So this is a patient who had multiple aneurysms, and we did bilateral surgery. We can see that in the right side of the patient, we did a minipterional approach, and in the left side, we did a pterional approach. You can see a slightly difference. In the pterional side, there's more hollowing of the craniotomy. Even more, this patient graded herself in the minipterional side as a 10 in the static results, and in the pterional an 8, which is not bad at all, but she was more satisfied with the minipterional results. Regarding complications, this showed no significant difference. There were few complications, but it's important to say the infectious ones, because of the epidural abscess, as we will see, as the minipterional does not have an opening of the frontal sinus, you can't have that complication in the minipterional group, but it is possible in the pterional one. So now we will see some clinical examples. This is a carotid ophthalmic aneurysms in a patient, an incidental one, who was operated through a minipterional approach. We can see how we can perform the opening of the sylvian fissure with a microsurgical scissors. We do it always beginning at the pars triangularis, where we know there's more cerebral retraction there, and it's easier to start dissecting. Now we're seeing the dissection of the aneurysm sac, and we're opening the falciform ligament, and we'll see that, as Dr. Rubino said in his conference, not all the paraclinoid aneurysms need to do a complete anterior clinoidectomy. In this case, for instance, by opening the falciform ligament, we were able to see the proximal axilla of the aneurysm, and later on clipping it. So you can see that in the microsurgical view, it's not different from the pterional approach. Later on, we will show you some images comparing both approaches and both views. So after putting the Doppler probe that showed that the aneurysm was completely clipped, we are now coagulating it, and we'll see the final image of the clipping. This is another patient with multiple aneurysms who was operated on one side first, and now, I'm sorry, now we'll show you. He had 3 aneurysms that we will approach through a minipterional, which is silvian bifurcation, a choroidal aneurysm, and a P2 aneurysm. This is a posterior view of the aneurysms. This was already explained by Dr. Rubino the other day. So here we have the first image to compare the minipterional incision with the pterional one. We continued with interfacial dissection, the craniotomy and the drilling of the sphenoid wing, and we'll start with the Sylvian fissure dissection. As we said, starting in the pars triangularis, going from distal to proximal, from superficial of the fissure to the depth. We can already see the Sylvian bifurcation aneurysms. And we will continue with the dissection because, as you know, when there are multiple aneurysms, we need to clip them from the depth to the surface so that the different clips don't get into our way while we are dissecting. The previous one was the choroidal aneurysm, and that last one, which is the more deeper, is the P2 aneurysm. So we can see how the approach gave us the exposure and the room to dissect and to clip with no problem. So now we are with the anterior choroidal clipping of the aneurysm. And last, with the Sylvian bifurcation aneurysm. We clipped it, we control the flow of the temporal and frontal branches. And we will add a second clip to complete the exclusion of this aneurysm. So as you can see, the maneuvers and the dissection is as if we were working also through a pterional approach. Only there's less cortical surface exposed, which will be more beneficial to the patient. This is the post-operative angiosity. So as we were saying, we can see in purple the minipterional incision and in black the pterional incision. This is a direct dissection here. The craniotomy is the one of a pterional. As you can see, the extension in the frontal bone and the large dissection in the temporalis muscle as you compare it with the minipterional. You see all this temporalis muscle, which is again not dissected. And we can describe the main advantages of this approach, which are a smaller craniotomy, less muscular dissection, the preservation of the superior temporal artery, which in the minipterional one, you won't have it in your way. The minipterional approach, as the craniotomy is done completely below the superior temporal line, does not violate the frontal sinus, which not always is opened by a pterional approach, of course, but this prevents any infectious complications. There is less surgical duration, which is important, as you know, as well for infectious complications, better aesthetic outcomes, even graded by the patients itself. And the most important thing is not that it's only smaller or that it's, you know, something popular or changing because it's just minimal invasive, but it reduces the extent of the craniotomy without compromising the exposure, the surgical exposure. Of course, in the properly indicated. Of course, it has disadvantages as well, which is as the incision is smaller, there's a bigger flap retraction. In subarachnoid hemorrhage, sometimes the brain is very swollen, so they won't be so indicated for the minipterional approach. And there's the retraction of the frontal lobe might be limited because the craniotomy is not so far in the frontal bone. We have an anterior view of this cadaveric specimen where we have the minipterional approach in the right side of the head and the pterional approach in the left side, where you can see the exposure of the superior temporal artery, more temporalis muscle dissection, and a bigger craniotomy, which can get to the frontal sinus. So as we were saying, these are the pictures of the cortical exposure of both approaches, which is clearly bigger in the pterional approach, but the importance is that the microsurgical view and exposure is similar. As you can see here, posterior communicating aneurysms in both patients. In this case, a Sylvian aneurysm in both approaches. So Figueredo was the one who popularized this approach, and he did a comparison between the surgical exposure of both approaches, the pterional and the minipterional. He concluded that the size of the bone flap optimizes the surgical area without compromising the surgical exposure. He also did a measurement of the angular exposure, where through the transsylvian route, there were no differences. But you can find, as we were saying before, because of the limited frontal craniotomy, that if you need maybe a more anterior perspective, the exposure is a little bit restricted in the minipterional. And he concluded that the main indications for this approach were the incidental aneurysms of posterior communicating artery, carotid bifurcation, MCA, and the anterior communicating artery. Nevertheless, people continued popularizing this approach, and as Dr. Mura showed us yesterday, they expanded these indications to ruptured and large paraclinoid aneurysms, because Dr. Mura added to the minipterional approach as well the extradural clinoidectomy with mini fossa media peeling. So they expanded all these indications. This is another prospective study, in this case, with 58 patients who also included ruptured aneurysms, and they didn't find differences in the clinical outcomes, but they did find significant difference in the cosmetic results, being better for the minipterional group and the temporalis muscles atrophy. This other paper with 82 incidental aneurysms, which concluded as well that they had no instances of suboptimal operative corridors or clip applications with this approach. Our conclusions are that in our initial experience, the minipterional was an effective and secure alternative for microsurgical clipping of proximal cerebral aneurysms. The main objectives of every cerebrovascular surgery were accomplished, which are gaining proximal control, gaining the clipping of the aneurysm and the preservation of perforators and parent vessels. We did find significant differences in the less surgical time, less hospital stay, and better aesthetic outcome. Anyway, we know that this is a complementary feature to traditional approaches that had precise indications as being an incidental or low-grade subarachnoid hemorrhage aneurysms without clinical or imaging signs of brain swelling or hematomas. Thank you very much for the opportunity.
Thank you, Dr. Clara Martin, for your excellent lecture. And we invite you to write your question in the chat and will be read.
See, I forgot this, if there are questions, just put them in the panel box if you'd like, or you can come directly on the screen. Clara, everyone's quiet today.
I'm sorry, I didn't have the camera on the whole time. I'm sorry.
Well,
no, my intention.
No, we
I
were watching
just
your
realized. I'm very sorry.
Don't worry, doctor. It was an excellent presentation. And I have a question, if you let me. Are there any contradiction to clipping?
I'm sorry.
I have a question. And
yes.
Are there any contradiction to clipping to this procedure?
Is there any relation to clipping? What's that again?
Contradiction for the clipping?
Diga en español.
Oh, okay. So what we do after the clipping, we use the Doppler probe, and we also puncture the aneurysm and coagulate it. And after that, we do an angio-CT post-operative.
Thank you.
Thank you, doctor.
You're welcome.
Okay, I guess we can move on to the next lecture. And I'm wondering who it is too, Francisco. Is Dr. Llanos there? Or moderator?
I'm sorry, doctor?
Yeah, is Dr. Llanos there for the next speaker? Thank you very much, Clara.
Thank you.
Thank you, Dr. Clara.
Okay, we're trying to get the next speaker. Margarita, could you just text me and let me know who the next speaker is?
Dr. Llanos is doing some signs. You're muted, Dr. Llanos.
Oh, okay.
He's speaking, but we're not listening.
Okay, now I'm here, but under Maximiliano Nunez, because the next speaker will be Maximiliano Nunez, another neurosurgeon from Argentina, from the same hospital as Dr. Clara Martin. But first thing, I want to say a few words about the beautiful presentation of Dr. Clara Martin. Couldn't agree more about the indications of the Minipterional approach. Sometimes in rupture cases, we can't do the Minipterional, especially when we're planning in the worst cases, when the craniectomy is an option. But in the rest of the cases, I couldn't agree more with you that we can do it. And you have showed us quite well, even multiple aneurysms can be done. Thank you very much for your cooperation with this course. I hope to meet you in the near future with Pablo. We can invite you to other courses. Thank you very much.
Thank you very much.
Thank you. And now our next speaker is Dr. Maximiliano Nunez. He's been with us in Madrid in the course. He attended the course during the last couple of days, and he's been giving us lectures about the white matter dissection of the brain stem, combining the good thing this doctor is doing is that he combines the advantages of probably the best white matter fiber dissection in the world with the cranial base and the vascular ideas and approaches. Now he's going to talk us about the approaches and the anatomy step by step and layer by layer of the fourth ventricle. No, so I leave you with Dr. Maximiliano Núñez.
Ya lo tengo conectado. No. Para buscarlo. Doctora Clara Martin, excellent presentation. I'm very proud of you. One of the best residents I never see. Está en el disco duro. ¿Este presente? Puede ser. No, en la carpeta. ¿Cómo tiene el nombre? ¿Cuál es? Este es. Lo buscamos como Madrid.
Yeah, share screen at the bottom.
Es este.
Margarita está allá para mostrar.
Dame tu disco.
Dr. Llanos,
¿Te puede pasar ahí?
para mostrar cómo compartir la pantalla, por favor.
Un momento. Ahora lo compartimos. Ahora lo compartimos.
This is Martina, who organized the whole conference. Say hello, Martina. Okay, very good.
Cuando estamos varios, ¿no?
No lo lee.
Porque es de Apple.
Este es de Apple, pero recién lo leí. Había entrado. No, ese trasero no era.
Es un PowerPoint.
Este es un PowerPoint.
Sí. Lo cambiamos entonces. Como cambiaron rápidamente, después rápidamente lo metemos la presentación por disco. Yo creo que este tendrá que ir.
Eso es bueno.
Hostia, no.
Se queda así porque se está al revés, tranquilo.
Vale, sí. Y luego tienes la grande para tenerlo.
Este no tiene este puerto.
Tienes, si la tú le tienes.
Ah, sí. Estaba un PowerPoint. Sí, estaba PowerPoint. Madrid.
Te salió libre también.
Es esto, Madrid.
Pero mira, voy a ver si te entras, ya sé.
Está buscando para la fila, ¿verdad, Margarita?
Yes, they are.
Sí, abre la fila de la charla.
Ahí está. Uy, datos en
Madrid.
esa.
Esta,
Sí,
esta, seguro.
sí.
Madrid. El copia mi Madrid, ¿no? Dejamos compartir. Compartimos, compartimos.
Ya está
¿no?
compartido.
Ahora vamos a
Dale
maximizar donde se
dale
ahí abajo. Es que se nos tapa, ¿no?
Presentación con diapositiva.
Perfecto. Here you go.
Hello, my name is Maximiliano Nunez. I want to say thank you for the invitation here in Madrid to the course, to the organization, and it's my privilege to share with you this short talk about the different approaches and different structures about the foreventricular floor. Everybody knows the foreventricular floor is like a minefield, because we have many structures inside, many tracks, long tracks, and many nuclear groups. That is the reason why it's so difficult to choose the best approach to reach some disease like cavernomas or some tumors inside or in the superficial phase of the foreventricular floor, even inside, in the middle, or inside in the body of the brainstem at the level of the foreventricular floor. Everybody knows the foreventricular floor can divide in three portions. One superior triangle, inferior triangle, and in the middle, the junctional portion between the foramen Luschka to both sides. The next slide. Here, you can see the different safe entry points. But I want to say something. I don't believe we can talk just for this like a safe entry point. My concept is entry point in the foreventricular floor, like another part of the brainstem, is some controversial concept because it's no real safe entry point. I suppose it's more accurate entry point, but the concept is to know what the structures are not just inside in the body of the brainstem, in this talk at the level of the floor of the foreventricle, not just the anatomical structure. Even for me, it's more important the interpretation when you have some disease, because you must be have one adapted concept, adaptation in your mind to understand how can change the normal anatomy in order to the interpretation with the disease itself. That is the reason why I put this slide. You have in the A point, supracollicular approach, of course in B, infracollicular approach. The C point is in the middle line. In the middle line is controversial just in the case when the disease have some expression in the foreventricular floor, of course. But the reason why I say that is because here in both sides of the middle line, everybody knows we have the medial longitudinal fasciculus. The medial longitudinal fasciculus is 1 millimeter more or less in the deep of the foreventricular floor. The reason why I say that is because you damage this longitudinal fasciculus, and one tip, the longitudinal fasciculus is one bundle. The truth is two bundles, one side and the opposite side, but it's not the fibers don't run to up to down or down to up. It's in both sides, in both ways. But this bundle of fibers connect the nucleus of the 6, the nucleus of the 4, and the nucleus of the 3 cranial nerve. That's the reason why if you damage, you can have some problem like ophthalmoplegia, internuclear ophthalmoplegic problems. Everybody knows that. We must be preserve the middle line. Just in few cases you can access, obviously with monitoring and monitoring and very careful decision in what point you must do the cortisectomy. The D point, like everybody see in this presentation, is the acoustic approach. The acoustic approach is just next to the E point, the lateral recess. Everybody can read or can consult the papers about Dr. Matsushima. When you read the paper, it's so clear to understand the lateral recess approaches. He described three pathways or three different angles to attack this area. But to end this entry point, you can access to the inferior peduncle through the F point, inferior peduncle access. Like I said before, the foreventricular floor is divided in two big triangles. The superior triangle is bigger if you compare to the inferior triangle. The population of the nuclear areas or nuclear structures and bundles in the inferior triangles is worse, is more delicate even to the superior triangle. But what is the limit of these triangles? In the superior, the limits are the superior cerebral peduncle, and the inferior triangle, the limits are or must be found through the inferior cerebral peduncle. The middle cerebral peduncle don't conform the walls of the foreventricular floor. That is a very important concept to keep. This schematic, very complicated, in my opinion, paint about the relationship in the foreventricular floor of the reticular substance, the reticular system of nuclear, like everybody know, like we study in many books. It's important to understand and to create one idea what's happened if I access in the supracollicular space or the infracollicular space. In the middle line, in red, you have the most important group of reticular substance nuclear. They are very important because the damage of this structure can be or can do one devastation in the patient or never wake up. But the point is, you can see the 6 cranial nerve nucleus and the pathway of the 7 cranial nerve around it. Superior to it, you have one space a little bit more bigger to the inferior collicular approach. The problem is not just that. The problem is lateral to this area because in blue, in the circle, you can see many different structures. In my opinion, the most important is the second. I don't know if you see my arrow here is the nucleus of the coeliac foot. The coeliac foot nucleus is very close with the another group of cellular is the nucleus ceruleus, as the activation of this nucleus and the connection with, for example, the salivatory nucleus and the connection with the 10 nucleus, the nucleus of the 10 cranial nerve, can be very specific concept to understand when you push the superior cerebral peduncle, because when the tumor is attached to the superior cerebral peduncle, to the border of this peduncle, and you push, for example, one tumor inside the foreventricular floor, you can create some problem in the respiratory frequency, and that can be impact in the heart beat. I say in the heartbeat frequency. That is very important. One bradycardia can be do it for you if you push in the superior aspect of the cerebral peduncle. Obviously, the most important structure here is the facial nerve and the nucleus of the 6. Everybody knows that. My idea is to preserve that. But to understand in different level, at the level of the junction between the pons and the medulla oblongata, is one axis. At the level of the pons itself is another entry point, but in the junction between the mesencephalic area and pons is the third approach. I show you in the lower part, at the level of the junction between the pons and medulla oblongata, you have 3 points to access. Of course, by the middle line, you must be paid the price. Why? Because in this aspect, you can damage the sensorial pathway coming from down to up, and before to the causation posterior to the aqueduct here, like a medial meniscus, everybody knows that. What happened is the lateral sulcus, if you put the gracilis tuberculum, you can access in the second point in 45 degrees, of course, through the inferior cerebral peduncle. If you go more lateral and ventral, you can reach this area lateral to the gracilis accunatus nucleus or fasciculus, and you can reach the most lateral aspect of the medulla oblongata. Of course, that if you continue with this description, here you can see the cut is at the level a little bit superior, at the level itself of the inferior cerebral peduncle. Everybody knows we can access to the inferior cerebral peduncle. Of course, here the cause is the damage of this bundle of fibers, and everybody knows this peduncle project the fibers to the cerebellum. That is very important for me. If you access in the middle line, you can damage the floor, ventricular floor at the level of the obex. Even there, you have many important structures because it's the lower part of the calamus scriptorius, where converge the 12 and 10 cranial nerve. You don't want go for this way. Lateral to it, you have the vestibular area, like a first slide I show you. You can access, obviously, it depends the position of the disease, the cavernoma, or wherever you have, but the price is the lesion of this group of nuclear, superior, medial, lateral, inferior. What's happened if you go through the inferior cerebral peduncle? Here in the big narrow, of course, the restiform body or the inferior cerebral peduncle itself can be damaged, but sometimes it's the only way to access, and you preserve the reticular substance in the lower part of the foreventricular floor. That's the reason why if you cut just a little bit superior at the level of the pons, the pathway here to preserve the reticular substance is, of course, you can go through, like here you see the green narrow, through the superior colliculus approach or inferior collicular approach. This is the most important concept to keep in this presentation in this moment. I want to change my slides just to show here. This is the cadaveric dissection. I do this just to understand very careful the position of the many structures. Like you see here, the superior triangle is the most big part if you compare with the inferior triangle. In my opinion, the inferior triangle is most challenging, is most difficult to access, and no, for the approach itself, it's more difficult to decide what is the entry point. It's the challenger here. What's happening with this middle part? The middle part, the most important landmark is the medullary striae, but they show to us the position of the foramen of Luschka. We can access to that because we can go through the foreventricular floor in order to reach the lateral recess. Everybody know that. What happened in the superior triangle? The superior triangle have one limit. The inferior is the junctional part. The superior is the aqueduct, and the both sides are complete with the superior cerebral peduncle. What happened when the superior cerebral peduncle? Like I said before, the relationship with many structures and the connection with the nuclear of the 10 cranial nerve is crucial. Even if you don't damage this connection, you can damage the superior cerebral peduncle itself. What is important here? The cerebral peduncle, the superior, have 4 groups of bundles: superior or dorsal, inferior or ventral, medial, and lateral. When you damage from inside this peduncle, you damage the more medial aspect of them. But this fiber is important because the projection through the dentate nucleus to reach the mesencephalic portion and make connection with the red nucleus, they project from the red nucleus to the thalamus, and after that, the projection is to the premotor cortex. If you damage part of the superior cerebral peduncle, you can have some syndrome, like, for example, the patient can access to pronounce the words. He knows what he wants to say, but it's impossible to reach in the mind the words and to express. This is a very important concept, in my opinion, to the application of the anatomy and the surgery. Now I want to show you the lateral and sagittal view. If you want to say, if you want to say sagittal, of course, the most important here is the relationship with the superior cerebral peduncle, like I said before. You can see the middle cerebral peduncle never can form the wall of the foreventricular floor. This is outside, but the superior is very important, like I said before. I want to show you this is the lateral mesencephalic sulcus and the relationship with the lateral aspect of the brainstem. This is another view. This is the more delicate and accurate dissection. Many structures is around or are around the lateral mesencephalic sulcus. Of course, you can see how can the medial, the lateral lemniscus in this position is over the superior cerebral peduncle. The lateral lemniscus is part of the pathway between the inferior colliculus and the fibers coming from the pons in the pathway of the acoustic system. I want to, in order to respect the time, I want to show you this another slide. To understand the foreventricular floor, you can study the foreventricle from outside, from the back, or from the ventral portion. You see, this is very interesting. At the level of the pons, if you dissect and you remove all the structure from ventral to dorsal, the first fibers or first group of bundle you must be reached is the medial lemniscus. The medial lemniscus is protected by the stratum profundum. The first fibers anterior to the medial lemniscus is the stratum profundum. If you remove the stratum profundum, this group of bundles connect one side to the opposite side to the cerebellum, you can see naked the fibers of the medial lemniscus coming from below, from the posterior decussation at the level of the medulla oblongata. Everybody can see that. What happened here, if you this representation make correlationship with the schematic view. You see in blue, this is the stratum profundum. What happened behind is the medial lemniscus in orange. That is the reason why the medial lemniscus is a very important landmark, not just when you approach this area from anterior. It's more important when you reach the floor, ventricular floor from posterior, when you go through the floor, ventricular floor. This is very important. Now I can see and I can show you this slide in the strict sagittal view. This is complicated to understand because many structures are in this area, but to be more specific or more clear, I want to show you the next slide. It's very important for me explain the main structure here to divide the foreventricular floor from back to ventral, from the floor ventricular floor with the pons is the medial lemniscus. You see the medial lemniscus is in yellow in this slide. And the medial lemniscus divide the pons for one part ventral and one part dorsal. In the dorsal part is the main important structure because here the mensurance is almost 4 millimeters. In that 4 millimeters, you can reach all the reticular substance and even, of course, bundles and nuclear group of the cranial nerve. I want to show you this mensurance, but again, lateral view, a strict view. This is even important when you talk about foreventricular floor because many disease or many pathologies like a cavernoma can implague or can damage not just the foreventricular floor, a little bit more lateral. Maybe you can choose another way, but to discuss this way, you must know not just the foreventricular floor itself, even the lateral aspect of them. This is another view in the lateral, like you can see here the 5 cranial nerve and the group of the 7 cranial nerve and 8 cranial nerve. The window between both is very useful for us because you can choose this pathway in order to reach the most lateral aspect of the foreventricular floor coming from the lateral side. Even this view can show the mensurance of this window, and this approach or this entry point can be reached through the retrosigmoid approach. The retrosigmoid approach can be a very good option. I want to show you a little bit more accurate dissection. Here is the foreventricular floor with some labels. This label show to us in red the nucleus of the 7th nerve. You can see the 7th nerve, cranial nerve, nuclear aspect. You can see in blue the superior cerebral peduncle in this point. And I cut just in order to see the foreventricular floor and many structures like a spinothalamic tract. Here, the spinothalamic tract is just lateral to the superior cerebral peduncle and run below to the lateral lemniscus. What happened with the spinothalamic tract? They reach the mesencephalic aspect to make connection with the thalamus. Everybody know that. And in orange, we can see the medial lemniscus. This is very nice to see, but we can complete this explication if you now dissect and compare from ventral. If you remove just the fibers, transversal fibers, stratum profundum, you can keep and you can see the medial longitudinal fasciculus in yellow. Lateral to it, you can see the medial lemniscus. But what happened lateral here is the tectospinal tract. The tectospinal tract run in the deep of the foreventricle mensurans just to connect the tectum with the first 3 or 5 level of the medulla. That's the reason why we can see one object in the life, and we can move the edge and the neck in the same time. This is very important. That is the reason why we must be preserve the foreventricular floor. If not, we can damage this structure. Just to go a little bit faster, the schematic is not necessary, but now, in my opinion, this is the key point. When we choose entering the foreventricular floor, we must be decide middle line, for example, lateral recess, but if depend where is the position of the disease. For example, one cavernoma. If the cavernoma is in the superior triangle of the foreventricular floor, the one of the route to reach the cavernoma is the superior suprafacial approach. The suprafacial approach is the shape is like a triangle. What is the limit? The inferior limit is the superior transversal or horizontal branch of the seventh nerve. Everybody see in this case, I want to show now this here. Again, sorry. You can see the inferior limit of this triangle is the horizontal portion of the seventh nerve, intrapontine, of course. What is the medial limit? The medial limit is the medial longitudinal fasciculus. It's very simple now. And the lateral, again, sorry, the lateral is the superior cerebral peduncle. You see here, my arrow here. What's happened in the inferior portion of the, at the level of the inferior triangle? The approach here is the infrafacial approach. This shape is different with in the upper part. This shape, this approach or this entry point is a little bit minor in mensurance. We must keep very careful in order to don't damage what structure. The main structure here is the head of the 12th nerve and even the 10th nerve, because there is the position of the nucleus of the 10 and 12 cranial nerve. Even some structures inside in the deep is the central tegmental tract. The central tegmental tract is inside in the box, in the green box. That bundle connects the tegmentum with the olive and make connection with the leaf and make one retroalimentation with the cerebellum. That is very important too. Now I want to show you, this is full dissection on the foreventricular floor. In the left side, in the right side is intact. It's very useful to compare because in the real life, it's impossible to understand, it's impossible to be very clear the different structures behind of the surface of the foreventricular floor. That is correct. But if you keep in your mind the structures, the anatomical structure, you must do like a mapping in your mind, and with the stimulation, you can see the position of the facial colliculus, and if you find the facial colliculus, you can see, okay, below to it, for example, the infracollicular approach, and in the upper part, supracollicular approach. If you push lateral, you find the superior cerebral peduncle. If you push to medial line, you can damage the medial longitudinal fasciculus. It's very simple if you keep in your mind the anatomy of this structure. Now I remove the right side just to understand another landmark. Lateral recess and acoustic striae. The acoustic striae is very nice to see. Sometimes you can see in the real life, sometimes it's not. But if you find the facial colliculus below to them, you must be sure this is the acoustic striae. And if you follow to lateral, you must find the lateral recess and acoustic area and everything there. If you go to the left side, in the inferior peduncle, that window, the little window here, can show to us the position of the nucleus ambiguus. The nucleus ambiguus is a little bit in the interior, in the deep, 2 or 3 millimeters in the deep of the inferior cerebral peduncle. That is very important too. But what happens if you dissect the lower part, even inferior and lateral to the ovex? Because the ovex is the conclusion where arrive the lower part of the 12 and 10 cranial nerve. This shape is like a calamus. That's the reason why everybody know like a calamus scriptorius. But you have one middle line. The second is the lateral line or sulcus. They make separation because you have there the sensorial pathway running from below to up, gall and burdach or cuneatus and gracilis tubercle. If you remove the nuclear of this tuberculus, you can reach the fibers before to decussation. And what is the name of this decussation? Is the posterior decussation. The posterior decussation is the decussation of the sensorial pathway. After that, cross anterior to the obex to reach the ventral portion of the medulla oblongata, and after that, make one take one direction to up in order to conform, in order to be this structure, the medial lemniscus. You know that. Decussation of the medial lemniscus. That is right. You see here some landmarks just to be more didactic. Superior triangle, inferior triangle, suprafacial or infrafacial approach, and in the lower part, you can see medial posterior sulcus or posterolateral sulcus, intermediate posterolateral sulcus, and posterolateral sulcus itself. 3 points to entry. In this talk is not so important. In my mind, I keep the suprafacial and infrafacial approach, and of course, in the middle line. But remember, the middle line, middle longitudinal fasciculus is your limit. Here, acoustic area, and a little bit more delicate dissection, just to see in very close view. I cut the nucleus of the 6th cranial nerve. I put some labels in blue, like the nucleus of the 7th cranial nerve, and the inferior branch, vertical branch, and superior branch. You can see the inferior branch of the 7th nerve is the limit of the infrafacial approach. The infrafacial approach in the deep, you can find the central tegmental tract and the tectospinal tract. Lateral to it, you can find the inferior peduncle and, of course, the nucleus ambiguus. If you cross the line, you find the acoustic striatus, and this hole is the vestibular area. But what happens if you dissect the vestibular area? If you dissect by histological control, by books, you can find the nucleus and tract of the solitarium fasciculus. That is very important. And if you push the dissection, you can see the head of the 12th and 10th cranial nerve. And in the head of this group of cranial nerve nuclear, you find a little bit group of cellular. The name is nucleus prepositus and nucleus of Roller. Why is important? Because the connection between the 12th and 10th cranial nerve with the 6th cranial nerve and reticular substance in the floor of 4 ventricles is through these 2 groups of fibers. Here, inferior access. In my opinion, it's more complicated here. I want to show you just very, very fast. If you remove more anterior aspect of the pond, you see in yellow, medial longitudinal fasciculus, lateral, a little bit more ventral, tectospinal tract. This view is from the front. You must keep that. Lateral, central tegmental tract, and more lateral, and in an oblique view, you see in the point of green color, is the mesencephalic nucleus of the 5th nerve. What happened over them? You find the nucleus ceruleus, the most important noradrenergic concentration in the 4th ventricle floor. I want to pass this very fast because it's not making sense. And I want to share with you this. Just to finish, in the lower part, you see, if you dissect very careful, when you see in the histological view, that is true, because here, in the lower part of the obex, you can see I remove the nucleus cuneatus in part, and in this area, you see in yellow fibers before the decussation. And to the approach for neurosurgeons, for neurosurgery, for me, it's important to keep in my mind what approach I must be taking in my mind in order to reach the lower part of the medulla oblongata. In the A point, you can see the posteromedial sulcus. In B, you can see the posteromedial sulcus in B, and C, posterolateral sulcus. That is very important, and the comparison in the axial cut, sagittal cut, and some schematic view is no more like that. I want to finish here. This is a schematic, but of course, I think too much information is, I suppose, can be didactic. Thank you very much for this, for doctors here, for the organization. It's a pleasure for me to share this material, and I hope you like. Thank you very much.
Thank you, Doctor. It was an excellent lecture. And we want to say to all the people, if someone has a question or even a comment, can you let in the chat and we read the question or the answer and or the question or comments, and we'll answer the question. Thank you, Doctor.
Thank you very much.
And we want to say that after this Zoom, after all day of Congress, we invite you to Neurosurgery.tv Zoom Lounge. That the link is in the chat. That we are talking with speakers and students and some residents. That we want to say some question about the journey or some lecture or even talk with other people in the world. Thank you, Doctor.
Thank you.
Thank you so much.
Okay, Margarita, what's next?
No, we have finished today. Tomorrow we will be with Professor Tanikawa in the morning in Madrid.
Oh, okay, so we're finished for today?
Yes.
Yes, it is.
Okay, we'll see you tomorrow, and
See you tomorrow.
if you want to, and Dr. Llanos can come into the lounge to say hi. Maria, the link is in the chat. Can you get that link, Maria? Dr. Llanos, the link is in the chat to come into the lounge just to say hi to some of the students. Okay, get that link, Margarita. You got the link?
Thank you everyone for your assistance. Gracias a todos por su asistencia. Los invitamos al Zoom Lounge.
Okay, everyone got that link? I'm going to end this broadcast so you can go into the lounge. Okay, copy it real quick. And we'll get to meet other people. Okay, ending it now. Okay.